Hi guys, how's it going? Long time no see. All right, so as we attempt to do this virtual classroom, I will talk and play the PowerPoint, and we'll go from there. If you have any questions, please email me, call my office phone. Email's probably best. I'm going to try and work on getting some kind of virtual office hours going. That way you just log in, and then through your Confer Zoom link, we can chat. All right, so we're gonna start intro to the body. If this lets me, okay, there we go. We're talking about the integumentary system, the muscle, skeletal, and nervous systems. The circulatory, lymphatic, respiratory, and endocrine, we may touch on briefly, but not too in depth. Okay, so the integumentary system is the skin in any way you want to talk about it. It is the largest organ in the body. It is about 132 to 1/8 of an inch thick. So it's pretty small depending on the layer and where it's located. There are three main kind of layers we're going to talk about: the epidermis, dermis, and subcutis. Okay, so the epidermis is the top layer of your skin. That is your primary barrier for any kind of organism, protection from dirt, anything outside of the body. Helps maintain a lot of water. It contains a lot of little layers of skin. Your stratum corneum, granulosum, spinosum, basal, and then your stratum luctum is primarily on your hands and feet, only because those areas have higher friction, you do more grabbing, so just an extra layer on there that just gives you more protection. And as your skin kind of dries out and you use it more, some layers can get thicker. All of the skin that you see in yourself is actually dead right now. That top few layers are dead, and that's absolutely normal. And every 30 days or so, you'll shed a layer of skin, and the layers underneath will just kind of replace it. And that's just how it goes. And that makes it so that your top few layers aren't as sensitive as your bottom layers. That's why if you feel a little abrasion or you lose a few layers of skin, it's just more sensitive, like a blister, for example. So you got to wait for those bottom layers to kind of mature and essentially die. So it's not as sensitive. So you can go on your normal everyday life. Okay, your dermis, okay, located below your epidermis, obviously, maintains a lot of your water and electrolytes. It also contains a lot of your connective tissue. That gives you all that support to your skin so it doesn't tear or withholds a lot of tension through all the different forces and factors and bending, extending, and all those different things. A lot of your blood vessels are located in this area. You a lot of subcutaneous nerves, so nerves that are just the really, really small, tiny ones that are in your skin. A lot of your hair follicles and your sweat glands are located in this area. Okay, your hypodermis, okay, or your subcutis is your subcutaneous layer. Okay, the very bottom layer, as you see in the picture. You have more connective tissue in this area. You also have a lot of your adipose tissue, your fat, which gives you a lot of insulation and cushion. Okay, some injuries that you can get to the skin and directly below it can involve, one, the skin, two, the fascia, which is a deeper layer underneath the skin and the fat. And your fascia is this really kind of intense connective tissue that is everywhere. It holds your organs in place, upright. It holds your muscles down. It intertwines and becomes a lot of your tendons. It doesn't stretch too well. It's kind of like a spider web. If you could picture a spider web that you walk through, and you scare the crap out of yourself, and that's kind of broad all over your body, and it's really thick, and it's not parallel. It's just really kind of random. So you can damage your fascia. It takes a lot. Do some kind of incision will do that. Cartilage can be damaged. Again, these are really deeper injuries. Muscle, tendon, ligaments, and then veins and arteries can also be damaged. And some other different kind of classifications for open versus closed injury is an open wound is something that has punctured the skin. The skin is broken in some way, regardless what that is. And a closed wound is one that the skin has not been broken. Okay, start off with mild ones. Okay, the abrasion. Now you get abrasion from some kind of usually like skidding or turf burn, or you tripped and fell and scraped your knee on the asphalt or something like that. Looks roughly like the picture there. Hey, it's really shallow. It's really kind of pain in the butt. It's really easy to get any kind of like dirt or foreign particles in there, and a lot of time you can just hose them out. But let's say you get a lot of grass stuck in there and you don't get it out, it has a chance of getting infected. So a lot of time you have to actually scrub it out, which is not pleasant at all. Typically, you just gotta put some triple antibiotic over this and just kind of let it take its time. You can cover it, you can leave it totally exposed to the air, let it kind of like dry and kind of scab over nicely. And just keep it pretty much as sterile as possible, and it'll heal up over time. I've seen these as small as like a quarter, or as all the way down your butt and like outer thigh, depending on the sport or activity or how badly you tripped and ate it. Okay, lacerations. Okay, these caused by some kind of tearing motion, kind of like jagged, not really like a really clean cut. And these can be minor. Usually, times are going to go pretty deep. Okay. Now, laceration is just a cut. That's all you want to think about it as. You can, if the deeper you get, you can involve a lot of nerves, blood vessels, tendons, muscles, and you're not really going to know. It's really, really hard to tell. Like you look in the picture here, okay, that is a full thickness laceration, so it went all the way through the dermis. Okay, so this looks like a knee. So this is really hard to tell because the patella tendon is right there, right in the middle of that cut. So how much of that is actually affected? Tendons take a long time to heal. So that can be a really, really devastating injury. What else can that be affected? There's the meniscus in there, bone, cartilage. For sure, some nerves in the skin were damaged during this, so you don't quite know the full extent. Okay, so this is one you're probably just going to irrigate it. So just kind of like water, for example, like stick a garden hose, just get it out. You're probably not going to want to put soap because you don't want soap to kind of get in there too much. Pack it with gauze to stop the bleeding, and get them to like urgent care or some kind of doctor because they need stitches. Okay, and depending on what cut them, maybe a tetanus shot so they don't get tetanus. Okay, puncture wounds. Okay, so this can either be a miss of the hands, or a stabbing, or a gunshot, which is still a puncture wound. And let's say it is like a nail or a knife. Okay, you want to keep that in place. Do not remove that object, because whatever it is, if let's say it's going into the leg or somewhere in the abdomen or something like that. That knife, for example, can be occluding some kind of blood vessel. And then as soon as you take that out, it's going to open up that blood vessel and they're going to bleed out like crazy. So just leave it there. If anything, secure it in place, which sounds kind of weird. But pack it with gauze, and then wrap around it somehow and keep it in place so you don't move it because you don't know what's going on. In the picture here with a nail through the hand, okay, that first finger there, that is most likely some tendons involved, damaged. Okay, the second finger, that middle finger right there, tendons, you probably got some bone, it's a little bit deeper. And the third finger, or fourth, I guess we can talk about it, is you have tendons, you have now muscle attachments that's potentially damaged. And so if you tear that out, that's going to cause a lot of damage. And let's say it's a jagged object. Some nails, for example, or knives, they have they're not perfectly smooth. They have some kind of texture, whether it's lines or whatnot, to prevent it from coming out. So you rip that thing out of there, you're going to cause a lot of damage. If someone's stabbed by a serrated knife and you rip it out, well, that serrated part, where you usually use to cut the meat, that's kind of jagged, that's going to rip out more tissue. Okay, so you want, just don't let someone else that more qualified take care of that. Splinters, okay, really common, not really crazy bad. They can be very much a pain in the butt. Okay, this isn't the greatest picture, I apologize. But splinters can either be wood's a popular one, it can be metal or glass. So be very careful depending on what you're doing. Okay, wood splinters, for example, do not soak in water for any reason. Okay, wood soaks up water and expands, and then it's near impossible to get them out that way. Okay, a lot of times you just want to use tweezers and pull them out in the exact direction that it came in. Some get in there and they kind of break off, and it's really, really hard to get out, and you might need to go to urgent care, like a doctor, to pull those out. They might even have to lacerate the skin to get some of those. Metal splinters, okay, are hard as well because they like to stay in there and they like to keep burrowing themselves in. Glass splinters are really hard because it's really hard to see them. You just know it hurts really, really bad. And you gotta be careful of glass dust, which you can't see at all. And those can really get into a lot of different crevices and in, like, the webbing of the fingers and toes and cause a lot of irritation. For the most part, if you can get it out with tweezers, get it out. Keep it really, really clean. Even before you try and pull it out, okay, you wipe it with some alcohol, okay, and then pull it out, and then keep that clean. Put some triple antibiotic on there, and let it go on. All right, incisions, okay. These are more knife-like cuts. Kind of so much like a laceration in a way. If you go back to this picture right here, okay, a lot of times they're going to be long, similar to that, but they're not going to be as clean as that is. Okay, this is going to be like if you were cut by a knife or scalpel or something really, really sharp. Now these are usually really, really deep. Okay, they can damage a lot of different tissues. If this happens for whatever reason, okay, soap and water. Most likely they're going to need some kind of stitches. The common way of doing the stitches without needing a MD or advanced training is going to be what's called steri strips. If you look in the picture in the top right. Now, this is very similar to like the butterfly band-aids of the past, but these are better. So like just like that, they keep the skin closed. It keeps it closed, but it doesn't mean it keeps it closed under tension. Okay. Areas of like high tension, like on the knee, on the elbow, where it can bend, because if you put steri strips on like the elbow and you bend it, it's just gonna pop off. They're not like that secure. Same with stitches. Stitches can pop off, and they only get a little bit of the skin, just enough to keep it together. So some areas will actually staple with some kind of medical grade staples. Those areas of like high tension. And under no means, if someone has stitches, staples, steri strips, can they go back to activity until that heals enough to maintain that tension. And that's a big misconception. Oh, I'll get staples and go right back in to whatever game activity that I'm doing. Hey, not really the thing, because you could tear those out, and then there's more chance of infection, and then you have greater chance of scarring and stuff like that. Now, you can actually use super glue for all these different things. But there's there's a high chance of infection with super glue, and depending where you're doing it, can cause a lot of issues. So if in doubt, take it to urgent care, get some stitches that way. Super glue can cause 1, infection, 2, some scarring, 3, if you screw it up, it's a really, really big lawsuit, stuff like that. Okay, avulsion injury is some kind of whatever the mechanism happened. Okay, part of the skin, for example, is kind of flopped over. the cut is usually very long, not always very deep. Okay, and that part can get kind of flopped over. You might see this a lot with you have a blister like on the back of your heel. It starts to come off and it kind of flops down. Okay, that is like the more common version of an avulsion. Okay, this can be to bigger areas, and you want to keep that area clean. If it's still somewhat attached, you want to flop it back. Okay, that way that tissue can still use the blood flow there to reattach it and heal. That can heal right back on. All the time they may stitch it back down. If it comes off completely, yeah, you want to keep that moist and in a clean some kind of container or bag, and they may be able to reattach it in like the hospital, for example. Okay. There will usually be a lot of bleeding with avulsions if it does get like the full thickness of the dermis. Okay, there's a lot of blood vessels in there and bleed really, really, really quickly. Okay, let's talk about callus and blisters next. So calluses and blisters, they are as a result of friction, some kind of high friction. Calluses are really common on the feet and hands. Okay, so like lifters will get a lot of calluses on their hands just from lifting and moving the weight and that kind of friction that happens with the bar and the grip. A lot of running sports or runners in general get a lot of calluses on their feet, roughly in those areas there, especially on the big toe, especially if their shoes aren't fit properly or a number of different reasons. A lot of time they're not painful at all. They just look really bad. You can shave them off, and it's really, really easy. One, you can get a pedicure and they'll do that for you. There are ways to shave it off if they get so big that they cause a lot of pressure. And then it's a little tender after that, but not crazy, and they usually go right back to activity. Or sometimes you can file them down. Okay, blisters, again, high friction, and then you get this really kind of soft, squishy fluid built up underneath it, and that's just a reaction to the high heat. If you can, don't pop them. If you pop them, you can open up for bacteria. A lot of time they'll puncture it improperly. But before you even like worry about kind of draining it, you got to fix the problem. Is it footwear? Are your shoes fitting incorrectly? Is it the way you kind of run or move that's causing this blister? Okay, that needs to be addressed first, otherwise it's just going to come back and cause more irritation. Okay, a lot of times these will drain on their own, okay, and that's absolutely fine. Okay, don't force it if possible. Okay, and if it starts to like flop off, almost like the avulsion, okay, just flop it back. A lot of time they'll prevent more irritation underneath, so those bottom layers can mature and not be as sensitive anymore. Another good thing to use is zinc oxide. They use it for like diaper rash in babies. Okay, that can help mature that skin underneath. Okay, just like a baby's butt with a diaper rash. It doesn't hurt. Okay, just put it right on that blister and just kind of like let it air out. And usually within a few days, it'll be a little bit more mature. But you got to fix the cause of it. If it's footwear, their shoes wearing down. If you look inside their heel, is it kind of wearing down in there? You can even double sock. You can wear like a really thin nylon sock underneath and then put your normal socks on top. That way the socks rub against each other, not against the skin. Hematomas, okay, this is some kind of blood-filled area. This is a closed wound, so there's no bleeding that occurs outside. And usually some result of a soft tissue injury, okay, similar to some kind of like hematoma, okay, or bruise. And the best thing you do for it is the RICE acronym, which is rest, ice, compression, elevation. So rest is pretty much, okay, don't do whatever you're doing anymore, okay, or anything that's going to bother it, okay. Ice it, I think it will reduce the sensitivity and decrease the metabolism of that area. Compression will prevent it from getting crazy big and swollen. And then elevation is really only important if that extremity usually is really, really swollen. So you elevate that above the heart or as high as possible. So lay in your bed, put your leg all the way up on the wall, and you're going to try and get some of that swelling to migrate through gravity back towards the rest of your body. And not only if you have a ton of swelling is that really important. If you have little to no swelling, it's not going to do a lot. And you can ice no longer than 20 minutes. And you usually want to do that probably every hour. You repeat it as many times as you want. Okay, contusion. Okay, it's another soft tissue injury. This we could think of as that bruise. Okay. This is a traumatic blow to a part of the body, and some can be really, really bad, some could be not. Okay, so mild contusion, okay, that area is point tender, okay, so just when you touch it, it's tender, okay, it's not really super painful, a little bit, and let's say whatever body part is happening, above and below it, you have the full range of motion. That's what ROM stands for. You can move it fully, doesn't get in your way at all. Just if you hit it again, it's still tender. All right, a moderate contusion, okay, just like the mild, okay, now you have a little bit of swelling that occurs, okay, still point tender and painful. Some of your range of motion has gone down, when you're walking, you can't walk full. You may have a little lip now. And that's what the gait is how you walk, okay, some kind of abnormality is happening because you can't move it. You can't pick your leg up anymore because it hurts to move it back too far or something. And then a severe contusion is they're really, really tender. They have a lot of swelling, okay, in that general area. They have their range of motion's pretty much gone. They're unable to walk or have a really, really bad limp. Okay, that's upper body wise. They can't move that extremity for swelling or whatnot. Okay. So again, the RICE acronym is used here as well. For bigger muscles, okay, you want to ice that extremity. Let's say it's on your quad, for example. You want to ice that quad on a stretch as much as you can tolerate. Okay, so bend that knee. Okay, get ice on there, wrap it up. Okay, lay back down that way your legs somewhat elevated, and do that for about 20 minutes. Okay, so the important parts of those bigger muscles is when you ice it on a mild stretch, you're going to restrict the amount of blood that's going to stay in that area. Hopefully get it out. Okay. And that's important. We'll skip ahead. Is for this. This is called myositis ossification. Okay. And so look in the very bottom left picture, that X-ray there. Those two arrows are pointing to that really, really heavy cloudy area. That is somewhere on the quad, and that is as a result of repeated trauma, contusions, and a lot of blood that kind of sat there and didn't really leave the area. That blood started to turn the bone. Okay, so you have a bone formation. Now it's even better in the middle picture there, again on the quad area. That darker, more solid white cloud area, that is bone formation that's building up. Now that's really bad because now you can't move that quad anymore. Your muscle can't bend if there's bone embedded within it. So if you catch it early enough, you have to break it up, which is super painful. Or two, it gets really bad, they'll have to surgically remove that, which now you don't have part of your quad. In that bottom right picture, again, they had a knee replacement surgery. As you can see, the knee replacement really well. But then just kind of above that, you can see that cloudy area that doesn't quite fit in with the rest of the femur. Okay, and that is that ossification that happens. So with this, you kind of make sure you want to treat regularly. Want to get some really mild stretching in. You want to get the range of motion back first. Let's say it is a quad, like in these pictures, okay? After the first few contusions and you're still doing treatment, you want to prevent that injury from happening again. Okay, so you can pat around it, prevent whatever's happening so that doesn't get worse. You can get this, the quad's a popular spot, the arm's another one. You just want to prevent that from happening because all it is your body protecting itself. All right, I'm taking a lot of hits here. I want to lay down more tissue to protect myself. All right, now we're getting to anatomical positioning. Okay, and all these references are going to talk about kind of all like how your body fits. So if you're doing anything medical, well, this would be really, really important to know. So anatomical position is what you see the picture on the right, and that is that you're going to be looking kind of like straight ahead, your body's upright, feet roughly parallel, not together, your feet aren't together exactly, your arms are to your sides and your palms are out with your thumbs pointing outward. Okay, just like that. Okay, fundamental position, the exact same thing if your palms are facing your body. Okay, so anatomical position, your palms are up. Fundamental, your palms are towards your side. Now some more directional terms. Okay, anterior and posterior. Anterior means the front, either the front of your body or in related to something else, and posterior means towards the back. Okay, a lot of books will reference this as ventral and dorsal. For right now, we're going to use anterior and posterior. Okay, there is superior and inferior. Okay, superior is above and inferior is below. This can be as to the whole body or in relation to another structure. Okay, lateral and medial. Lateral is pertaining to the outside of that body or extremity, and medial is towards the inside. So if I go back in this picture in the anatomical position, your thumb is lateral to your pinky, okay, because it's towards the outside, okay? And then you can think of it as your knee is inferior to your hips, okay? You want to think of it like that. There's also proximal and distal, okay? Proximal is closer towards your body, usually towards like the your like trunk of your body, and distal is just farther away. Here's another this reference picture for you to check out. A few more terminology. Prone is lying on your stomach. Supine is lying on your back. Recovery position is side lying, usually on your left side. That's just side lying. Superficial is near the surface. Deep is obviously deep. Bilateral is pertaining to both sides, right and left. And then unilateral is pertaining to one side. Movements, okay? Some quick movements. Okay, you have abduction and adduction. Okay, so abduction, if you look at the picture to the right, he's lifting his arms out to the side. Okay, and when he lifts his arms up towards the side, that is shoulder abduction. The movement is happening at the shoulder joint. Okay, this can also happen at the hips as well. Okay, you have hip abduction, and you're lifting your legs out to the side. Okay, now adduction is lowering your arms back towards your body, okay, or hips or feet together. Okay, so like when you do the jumping jacks, okay, when you first kind of do that jump up, you are abducting both your shoulders and hips. And then when you come back down, when your arms are back towards your side, okay, you're adducting those back together. A good way to think about this is aliens abduct you, and then in math, you add together. Okay? Flexion and extension. A lot of people get these confused up really easy. So if I were to straighten out my knee, that is extension. If I bend my knee, that is flexion. Okay? If I bend my elbow, that is elbow flexion. If I extend my elbow, okay, again, that's elbow extension. Okay, now if I lift my shoulder forwards, okay, that's shoulder flexion. Now if I take my shoulder back, that is shoulder extension. Okay, a lot of people get that kind of confused. If I make a fist, that is finger flexion, and then I put my hand out, that's finger extension. Same with the wrist. Okay, a lot of other body parts do this. External rotation and internal rotation. Okay, now this happens mainly at some of these rotating joints, like you can use your head, your shoulders, your hips. Okay, so let's say what's a good way of describing this? Internal rotation of the shoulder is also called medial rotation. So if I'm rotating my shoulders inward, that's internal rotation. And then if I take them outward, that could be some kind of external rotation. Now, for whatever reason, my webcam isn't working. Otherwise, I would probably show you a little bit better. If it's a little too confusing, just kind of Google it real quick, like some kind of YouTube, and it'll show you what internal rotation is and what external is. Very good way to look at your feet. If you put your legs straight when you're sitting down, okay, and you point your toes inward, okay, that rotation is happening at your hips. That is bilateral, okay, which pertains to both left and right, hip internal rotation, okay? So it's rotating in. And your feet are pointing towards each other, your knees are pointing inward, okay? And that rotation is happening at your hips, okay? Now, if you point your feet outward, okay, that is going to be bilateral hip external rotation, okay? The same thing applies to the shoulders as well. Now, inversion and eversion, when you hear this is all talking about your ankles. Okay, so you look at the picture to your right. Okay, so inversion is you're rolling your ankle inward, and this is really popular to sprain your ankle. Okay, so it rolls inward. That is inversion. Eversion is you're rotating your foot outward. There's not a lot of range of motion to go out as there is in. But people a lot of really good inversion. Okay, dorsiflexion and plantar flexion. Okay. Plantar flexion is you're pointing your ankle downward towards the ground. So if you like go up on your tippy toes, okay, your ankle is in plantar flexion. Okay. Now if you're to walk on your heels, okay, you are dorsiflexing your ankles. Okay. And then pronation and supination pertains to your forearm. Okay. So if you were to hold a cup of soup, you're in supination. Okay. If you're going to dump out that soup, that is pronation. So palm up, supination. Palm down, pronation. Now, cardinal planes. Okay. There's roughly 3, 4 technically. It depends how you want to talk about it. This is just how you divide your body up in some kind of halves. Okay. So the frontal frontal plane. Okay. You're dividing your body in some kind of anterior and posterior segments. Okay. The median or mid-sagittal plane, you're dividing your body up in left and right parts. And the transverse is you're dividing your body up in some kind of upper and lower section, okay? And then the diagonal is some kind of combination of those different planes. So sagittal plane, okay, dividing your body up in left and right halves, okay? Mid-sagittal is right down the middle, or some kind of sagittal, could be off to the side. Now the movements that happen in this is the flexion extension, plantar flexion, anything that happens in that front and back plane. Okay, any movement that happens in that is going to follow under that sagittal plane. Okay, like a bicep curl. Okay, knee flexion, all that stuff. Okay, frontal plane, anything that happens because remember the frontal plane divides your body up in anterior and posterior, or front and back. Okay, so anything that goes out towards the side. This would be abduction, adduction, some kind of lateral flexion, Like you take your head left and right, okay? That's going to be in the frontal plane. Here's some more stuff, more movements, okay? So radial and ulnar deviation is a more advanced kind of movement. This happens at the wrist, okay? This is a more kind of an awkward wave. So if you take your hand flat against the table, okay? And then if you're only going to move your hand part, kind of glide it back and forth along the table, okay? If you migrate towards your thumb side, okay, that's going to be radial deviation. And ulnar deviation is going to migrate your hand towards your pinky, okay? That's what happens there, okay? And then inversion and eversion of the foot, okay, very similar to just inversion and eversion of the ankle, okay? Now we're talking about the foot here, okay? So it's very similar, okay? So inversion is you're going inward, and eversion you're going outward, okay? All these happen in that frontal plane. Okay, the transverse plane, okay, so this is where all your rotation happens. And here's a good picture of your internal and external rotation of your hips, okay? So the medial rotation, which is internal rotation, you see in the first picture, and the second one on the right, the lateral rotation, that is your external rotation that happens. Okay, diagonal plane, that is all your sport-specific or activity-related, okay? That involves some kind of rotation. Probably the hardest one is going to be golf, okay? So you have all these different planes that you have to kind of utilize in order to swing a golf club. A golf club is pretty much you're taking every single really simple motion and you combine it to make it really, really complex motion, and you got to make it as efficient and fluid-like as possible. For some of you guys that suck at golf, you know exactly what I'm talking about. All right, the skeletal system, okay, your skeletal system is roughly 206 bones-ish. Now, this depends on your stage of life, as when you're born, you have more bones in your body. And as you grow up, those bones, some of those bones fuse together to become one bone. We'll talk about that here in a minute. Okay, so bones provide movement. This stores a lot of minerals, mainly calcium. Also does hemopoiesis, okay, which is a kind of calcium component. It can divide up in your appendicular and axial. Okay, your appendicular is all your extremities, okay, arms, legs, feet, etc. And your axial is pertaining to the core of your body. Okay. Different types of bones. Okay, you have long bones, short bones, flat, irregular, and sesamoid. Okay, so your long bones are long. Exactly what it says. They're long bones. They serve a lot of levers for a lot of the major movements that happen. So, like your phalanges, your fingers, your tibia, fibula, in your lower leg, your radius ulna in your forearm, and your humerus, which is in your upper arm. Those are examples of long bones. Okay. The outer surface of that bone is usually called your periosteum. Okay. And if you look on your diaphysis, okay, which is that long cylindrical portion, okay, that outer layer, that white surface that you think about is bones is white. The outer surface is your periosteum. Okay. That's just an outer layer of that. And the inner layers are your diaphysis, or that fatty yellow marrow-ish areas. Okay. Your epiphysis is at the end of your long bones. Okay, it's usually some kind of like irregular shaped, and that just makes it easy to articulate with the next bone. Okay, so it makes it so it can bend or extend more fluid-like and easier. It's usually covered with some kind of hyaline cartilage to make it almost slippery. Okay, and it can absorb a lot of tension and pressure. Okay, usually some kind of spongy bone, okay, which can be really, really compact. Now your epiphyseal plate, okay, this is also called your growth plate. Okay, so when you're growing, this usually happens 9, 13 years old, give or take. Okay, when you're doing your growing phases, a lot of this growth occurs during your growth plates. So look in the picture here, you see that line that goes through your femur, and another one through your tibial. Okay, those are your epiphyseal plates. Okay. And once you're done growing, these plates close and they become solid. Now, different parts of your body, your growth plates, when they close at different time frames. We'll get to that here in a second when they close. But usually, all your growing can be done roughly about 25-ish. Now, if you get an injury to your growth plate, they can close prematurely. So let's say in your arm, your forearm, your radius, one of your forearm bones, let's say you get a fracture and that growth plate closes too early, okay, but you don't damage your ulna, okay, so your hand is going to grow in some kind of awkward medial or radial deviation kind of format. So you have a lot of issues with that. A lot of doctors, if you go in and during your adolescence before your growth plates close, you have an injury there, they really kind of freak out. Okay, short bones. Okay, these are more kind of small, cube-like. Okay, so your carpals and tarsals in your feet. Okay, and those are examples of short bones. Okay, they're not really long by any means. Okay, they're really, really kind of compact. It helps form a lot of support. Okay, flat bones are pretty much exactly flat, which in course, like your ribs are actually flat. All the pictures and cartoons you had growing up that show round, okay, they're actually flat. That allows them to bend. Okay, so you take a deep breath in, your ribs actually expand, and you push air out, they contract. Okay, so they're actually moving. Okay, so your ribs are considered flat bones. Your sternum, okay, right in the middle of your chest, okay, that is a flat bone. Okay, same with your scapula. Your skull is actually considered a flat bone. Okay, your clavicle, okay, going up almost in your shoulder. Okay, those are all considered flat bones. Okay, irregular bones. Okay, these are just bones that don't fit in any other category due to their complexity, shape, function, all that stuff. Okay, so your hips, ischium, and your pubic, excuse me, in your hip, in that top right picture, is all irregular bones. Okay, they're vast. They're a variety of different shapes and complexities. Also, a lot of your facial bones in your face, those are all irregular bones. Your vertebrae, okay, big irregular bones. Okay, sesamoid bones, these are kind of bones, they're usually really small, you don't have a ton of them, and their bones are usually encased within some kind of tendon. Okay, for example, in your hands and feet, if you look at those arrows, those are sesamoid bones. Okay, they're encased within a tendon, so they don't actually make contact with any other bone, and it just allows greater motion to occur. They can get inflamed. Okay, your patella is a sesamoid bone. It is a bone that is encased within a tendon. Okay, depending on your theory about the patella. Okay, so if you put your knee straight and relax it, you can actually grab your kneecap, okay, and glide it side to side. Okay, it's just encased within a tendon. Okay, that is your biggest sesamoid bone. Okay, a little bit more about growth plates. Okay. As I said, by around the age 25, most of your growth plates close. Okay, that's epiphyseal plate. Okay, this next slide shows roughly the age that they all do. Okay, so your vertebrae is towards the end. Okay, same with your ribs. Different parts of your humerus, whether it's the proximal part or distal. Okay, then your ulna and tibia next. Okay, and then your humerus is actually pretty early, your distal part of your humerus. Okay, and so if any of those close ahead of time, you can have a lot of different lengths of your bones. And some are common, Okay, let's say like one leg's longer than the other. That can be common where one femur is shorter than your other. It happens. Okay, injuries that can happen to the epiphyseal plate. Okay, there's 5 different types. I'm not saying that one is worse than the other. Okay, so in the picture, okay, the long part, your diaphysis, okay, and then your epiphysis is that distal awkward end that makes contact with usually another bone. And that kind of like grayish in the middle, okay, that is your epiphyseal plate. Okay, so we through all the different types, whether it is a detachment or a fracture all the way through or a crush injury. These are all what's called the Salter-Harris classifications of growth plate injuries. Any one of these can cause your growth plate to close prematurely, okay, which gives you a lot of issues. Okay. Now your bones constantly grow throughout your life, okay? Now osteoblasts and osteoclasts, okay, are constantly being worked, are cells that constantly work on your bone. The osteoblasts lay down new bone, and your osteoclasts absorb bone, okay? So your osteoclasts, let's say you need more bone for whatever. Let's say a woman is on her period, for example. Okay, she might absorb, or she might need more calcium for that stage, and so she might take that from her bones, like a little bit. And then as another example, if you start doing more physical activity, you're going to need your bones to be stronger, which they do become stronger during activity. It's a natural adaptation. So your osteoblasts will lay down more bone. Now, it's always constantly doing this, regardless of your gender and activity, but depending on your lifestyle can depend on a lot of stuff. The more physically active you are, the thicker your bones are. Being a big bone is actually a thing, not to the extent of what you think about it, but the more active, the more weight you have to kind of is forced upon your body regularly, the thicker your bones will be. They'll actually be rougher the bigger that they are. Versus if you're really sedentary, you don't do a lot of activity, your bones will be a lot thinner and a little bit more fragile. Okay. Next, we want to talk about Osgood Schlatters. Okay. Now, this is a injury to the in the knee. Okay. So if you look on the arrow there, okay, that bone fragment's kind of pulled off for the arrow. Okay, that is your tibial tuberosity, and you actually have a growth plate right underneath that tibial tuberosity that keeps that intact. Now, the tibial tuberosity is important because that's where all your quad muscles attach to. And so when that starts to be pulled off, it's essentially an avulsion fracture, okay? And so when it's pulled off, it's very rarely, very rarely, will it come off completely, the ball's off completely. Those get really, really inflamed. A lot of people, especially basketball players, you look at their knees, okay, right below the kneecap, and there's this huge bump. And all it is they had Osgood Schlatters, so I kind of pull that bone off, okay, and then your body won't let it kind of come off completely, and it'll just stay that way forever. Some people have them both, some people have it one versus the other, and it's just how they are. Okay. Now this is a kind of developmental injury, as well as a technique injury. Now you're only going to get this during your adolescence. Okay, when you're in your growth stage, because your bones grow really, really quickly. Your muscles can't keep up. That's why a lot of like teenagers, or sorry, young teenagers, or like middle schoolers, they're really, really tight. They lose all their flexibility because their bones are growing. And so they lose all that. So a lot of really like long-term stretching is really good to kind of prevent some of this from getting really bad. It's almost going to happen. But obviously the picture here, that's like some really, really bad avulsion fractures from Osgood Schlatters. And I like to show the worst the worst. But that's really what's happening. They then give a lot of issues with that. see, muscle bone strength imbalances. This is very similar to like Osgood Slaughters in a way, as in you're too focused on like one sport or one specific activity, and you overdevelop one muscle versus the other that does the opposite. And so it puts a lot of strain on one muscle versus the other. Like if you're just doing leg extensions, you're working out your quads a lot, you're not really working out your hamstrings, okay? So you got like muscle bone strength imbalances, okay? Let me see. And this can happen really anywhere. But the bigger one's going to be the Osgood Slaughters, okay? There's another one called, do I have the next one here? I don't. It's called Larson-Johansson disease. So instead of, it's similar to Osgood Slaughters, but instead of being on the tibial tuberosity, it actually happens to the patella, okay? Same, really, really painful. The treatment's the same, it's just where it takes place. And he actually pulls off that bottom end of that patella, similar to what you see in the picture here. Okay. Another weird thing is you can actually outgrow Osgood Slaughters. So you got a thing going back up to here. Once your growth plates close, okay, then you have to worry more. Okay, it's a lot stronger. Okay, so once that growth plate closes, that's it. Okay. Some overuse injuries that can happen. Okay, you have little leaguer's elbow. Okay, this is a premature closing of the epiphyseal plate in the elbow. So let me see if I can take pictures. Okay, so if you look at this picture right here, you see where my motion is. Okay, that part of the elbow has a bulged off, come off completely. Okay, really common in adolescents. Pitchers, when they throw too much, too fast, not enough rest, so that bone actually come off. And what they'll do is they'll come in and they'll have to just put a screw in and keep that in place. Okay, really, really common. And that's why there is now pitch counts in baseball. Okay. Now, why there is not in softball beats me, or in other sports as in tennis, volleyball, like outside hitters, when they do all that repetitive hits, and they have a lot of similar issues. Not as much with the elbow, but more like in the shoulder and other aspects. Okay. A lower one, okay, popular in gymnastics and swimmers, is called spondylolisthesis. Okay, if you can say that, great. Okay. So what happens is this is actually if you look right here, how that vertebrae is kind of displaced, okay? This nice curve right here, okay, right here is actually the bone, okay? And this right here is your spinal column, okay? So like part of the vertebrae inferior is actually displaced, dislocated, okay? From a number of different things, okay? This one doesn't look like there's a fracture, but you can have a fracture involved in here, which can displace that, and you get a lot of neurologic issues because now that part of your spinal column is now being pinched. Okay. You also get similar aspects from like fractures in your vertebrae, and all that's from the repeated extension of your spine, the compression, a number of different things. Come on. Let me see if I can pause this real quick. Sorry, quick break so I can give my son a snack. If you hear anything in the background, it's either my son screaming or it is Princess and the Frog because we are doing the overload this whole week. All right, continue. Joints and movements. Okay. Hopefully you guys can still see everything. All right, so some different classifications of joints is based on their material, whether it's a fibrous connective tissue holding the bones together, some kind of cartilage, whether it's a hyaline or fibrocartilage which holds those bones together, or synovial, or it's some kind of presence of the synovial membrane, which if you think about a joint, you'll think about a synovia. Okay. Joints can also be based on their movement, okay, arthrosis, okay, and they are either synarthrosis, which are they're immovable, or very, very little motion occurs, antiarthrosis, okay, they have limited motion, or diarthrosis, which is freely movable, okay. So you think about most of the joints, okay, elbow, shoulder, hip, knee, those are all diarthrosis joints. Okay. 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 Sinusoidal, okay, these are movable joints. Okay, so you look at the skull, okay, in that top picture, okay, these sutures of the skull, okay, in between those cranial bones, okay, are sinusoidal joints. Okay. Once your kid matures, those joints close, and they are truly immovable. So usually after like a year, when a skull kind of hardens, it does become movable. Okay, your gymphosis, okay, if you look in the bottom right in the tooth, okay, is a synarthroidal joint. Okay, that tooth kind of goes in place in the jaw. Okay. There's very, very little motion occurs there. There can get a lot of motion that can occur if you get a hit to your teeth, because they can wiggle very, very limited amounts. So you get like hit in the mouth, and they can wiggle and loosen up, because they're just held in place by ligaments, usually pretty strong ligaments, but they can loosen and come out. In the bottom right picture is your syndesmosis joint. Now, that is in your lower leg, high ankle region, and that is between your tibia and fibula. Okay, that is where those kind of two bones kind of interlock, and there's little motion that occurs here. You want to think of this as the area where you get your high ankle sprains, and more in depth on high ankle sprains. You take my athletic training PE class, you'll get more into it than that. Okay, but not a lot of motion happens here, and if the tibia and fibula do separate for whatever reason, usually it's a surgery to fix that, and that's beyond, I think it's 5 millimeters. It's as far as surgery, which, if you think about it, is a very, very little amount of play. Okay, your anteroarthrotic joints, since you have a little bit of movement, okay, is on the symphysis, okay, if you look down the picture, the very part of that is between your pubis joints, okay. That is your pubic symphysis right there, and that, a little bit of motion occurs there, because you need a little bit of that during just kind of a normal like walk, okay, but it's not a lot. And also between the disc and your vertebrae, okay, there is some limited motion that does occur there, okay, whether it's your rotating, okay. So when you like rotate your spine to like look around, okay, between each vertebrae, there's only getting like maybe 10 degrees of rotation that's happening, okay. But if one rotates, and then the one above it rotates 10 more, and one above it 10 more, then you can get a lot of different rotation occurs if all your vertebrae have that motion, okay. But if one of those has limited motion, then it's going to dramatically reduce the amount of rotation that happens there. Okay. Your diarthroidal, okay, or your synovial joints, Okay, these are your freely movable joints, the joints that you usually think about. Usually have some kind of synovial membrane. Okay, now this synovial membrane or capsule is around all your different joints, and this helps keep the joints in place. It houses synovial fluid, which is this fluid that's full of like nutrients to help keep that inner aspects of that membrane, the distal end of that joint nourished. Really important for that. You can damage the synovial membrane. If it is damaged, it can heal back pretty good, but you can have a lot of issues. You can result in a lot of instability from this. You can really see the membrane really easily on those people that are really, really skinny, distance runners, or people with some kind of anorexia. If you look at their fingers and their knuckles are really, really big, that is the synovial membrane that makes it that big. If you sprain your finger really badly, and that finger is now just really kind of fat, a lot of times it'll be like that for months, years, a few times the rest of your life. It's because that synovial membrane got so inflamed and pissed off that it is now permanently that way. Okay. And some different kind of freedoms, I'll say, depend on how much different planes of motion that they have. Okay. So depending on the textbook, you'll see like, oh, they have 1 degree of freedom. Okay. Like your elbow has 1 plane or 1 degree of freedom. Okay. It only flexes and extends. Okay. Your knee is actually has 2 planes, because not only does it bend and extend, but it also rotates. There's a little bit of rotation that occurs in your knee naturally. Okay. Again, we'll get more in depth on that, and that is a more advanced class. Okay. Your shoulder has 3 planes of freedom. Okay. It could flex, extend, adduct, rotate, glide, a lot of those different aspects. Okay. The joint capsule, okay, varies in size. Your shoulder capsule is pretty big because of the articulation between different spots between the 2 bones of your humerus and your shoulder girdle. Okay, is not as good as you think it is. So that's a pretty big capsule right there. That helps prevent a lot of like shoulder dislocations. Okay. Your synovial membrane is also made up of a lot of ligaments that help keep it that strong. And once you stretch it out, it usually stays that way. Like if you dislocate, if any of you guys have ever dislocated a joint, they usually say once dislocated, always dislocated. Because once you do it the first time, it's really easy to do it again now. That will happen the rest of your life. In your joint capsule, there's a lot of proprioceptors, okay? And that is some of your feedback. This is more neurologic. That helps detect angle, positioning, change of positioning, movement, and so forth. That way you don't have to look at every joint when you move it to know where it's at. Excuse me, why get my kid from feeding the dogs, okay? So that synovial fluid, okay, I said earlier, helps lubricate and nourish the joints. Okay, so it makes it very fluid-like and easy to move. So when you bend and extend your knee, okay, it's really easy like that because of that fluid in there, that synovial fluid, on top of other stuff as in your meniscus and stuff like that, which also plays a factor. But really, really important to have. Hope you guys really like the music in the background. A lot of people after like a knee injury, they'll want them to still do some kind of activity. Let's say it is the meniscus in the knee, which is kind of like a pushing shock absorber. Okay, so that synovial fluid helps keep that meniscus alive and nourished, because in your aspects of that doesn't get any blood flow. The only way it can is through normal motion. So a lot of time, if you're like middle-aged and older, they'll have you just do a lot of biking. Okay, really light, low-impact activities. Okay, is really good to reduce the compression factor on the knee, and helps kind of rotate all the synovial fluid to help nourish different spots of that meniscus. All right, muscles. Okay, they produce movement, they maintain posture positioning, and help stabilize the joint. Okay, now it is not a good stabilizer for joints. Okay, but it does do a stabilizer. Okay, so your primary stabilizer is your ligaments, and your secondary is your muscles. Okay, movement. Okay, obviously, posture and positions. Okay, muscles do a lot of posture, whether you believe it or not, as everyone's slouching, trying to watch or hear this video. Okay, so once your posture fails, then you get tired. Okay, you got to build and maintain that posture so that way you can last longer. So you can sit up for longer periods of time and before you start to squat. My kid just threw applesauce on me, and I'm covered in applesauce. Great. Okay. Your muscles also are excitable, and they can contract. So your nerves, okay, in a response that can excite your muscles to produce tension. Okay. And that tension, once they contract, okay, can create more tension. That made no sense as it came out of my mouth, but oh well. Okay, so the nerves send a signal down from your central nervous system. Okay, usually it's a chemical response, and which excites your muscles. Okay, and depending on what you're trying to move, okay, excites more what they call motor units, which excites larger groups of muscles to produce some kind of tension and movement of your muscles. Okay. Your muscles can also extend. Okay. They can stretch beyond their resting length. Okay. They're also elastic in a way. Okay. So they can go beyond their normal kind of length and then return back. Okay. If it goes too far beyond the normal resting length, you can result in injury, hence a muscle strain. And it takes a long time to return back. Okay. Now, the elasticity, you can actually train that so they become more flexible. For example, the long-term stretches, okay, your muscles can become longer. Okay. Hence, if you're trying to stretch to get more flexible, okay, you can train that elasticity to an extent. Your muscles have, some are primary movers, okay, so that's the muscle predominantly responsible for the bigger motions, okay. So like your gluteus maximus, okay, your big glute muscles in your butt, okay, they're primary movers for like walking, running, jumping, etc. The assisted movers, okay, are only, muscles are only used when more force is required. Okay, so some muscles are going to pick up, like they're still engaged, but not to the full extent unless you really need to lift something really heavy or beyond what that primary mover needs to be. Okay, so you can bring in these assisted movers, where some muscles are primary for some things, but they're just for others. Okay, you have agonists and antagonists. Okay, so your agonist is a primary mover. Keep throwing stuff at me. Okay. And that's be your primary muscle for whatever object you're trying to do. Okay. If you're doing a chin up, okay, your bicep is a primary agonist. Okay. Your antagonist is the opposite of that agonist. Okay. Really important for a lot of aspects. For one, you have to slow down the agonist. Okay. So your antagonist usually has to slow down the agonist. Okay. Because if your agonist contracts really, really hard, really, really quick, okay, it's usually going to damage something, whether it's self or the antagonist. So the antagonist has to slow it down. So let's say, we'll use running for example. Okay. Your quads are really important for running. Okay. When you're swinging a leg forward, okay, your quad and your hip flexors are your primary agonists. Okay. They're some of your prime movers for that. Okay. Your hamstring and your glutes have to slow it down. Okay. It slows down that leg from swinging forward. Okay. Otherwise, it's just going to keep swinging forward. So a lot of times, the antagonist muscle is really, really important to train. Pitchers, for example, baseball, softball, everything. Okay. Their antagonist muscles are their predominant muscles that they exercise to reduce injury. When a pitcher throws the ball, after he releases that ball from his hand, all his antagonist muscles have to slow his arm down, or he's going to result in some kind of injury. Which is usually the rotator cuff and upper and middle back muscles. Really, really important muscles to train. Okay. You have stabilizers and synergist muscle. Okay, so your stabilizers, okay, stabilize that joint, muscle, extremity, whatever it is. Okay, that allows for greater contraction of your primary movers. It reduces injury. It makes things more efficient. So you have a ton of hip muscles that you have never heard of before, and a lot of those, okay, are stabilizers. Okay, your gluteus medius on the outside of your thighs, so outside of your hips, is a really popular stabilizer muscle in runners. Okay. Synergist muscles, okay, can assist the agonist, stabilize as well, can really kind of refine a lot of movements so they're not really as sporadic. Okay, so you're not moving around like my kid ran around like crazy, swinging his arms everywhere. Okay, it's not really efficient. Okay, and every muscle does more than one function usually. Okay, whether it is a primary mover, okay, which can also be an assistant for a different motion. Okay, or it could be an agonist or antagonist depending on whatever function it's operating in. Okay, some different muscle contractions. Okay, so a static contraction, okay, is an isometric contraction. Okay, so if you're holding your arm out, okay, there's no motion occurs. Like you see in the picture, in the very top one, isometric. Okay, so his arm's out to the side. Okay, his deltoid is holding it there. Okay, there's no joint angle occurs. No motion occurs at the joint angle. Okay. There is isotonic, okay, which there's some kind of movement that occurs. So there's concentric and eccentric motions. Okay. So the concentric is the muscle is shortening, okay, under some kind of tension. Okay. And eccentric is the muscle is lengthening. Okay. So concentric, the force developed is greater than the resistance. Okay. So your body recruits more motor units to move that extremity beyond that tension. For if you're doing bicep curls, for example, okay, when you're lifting that up, okay, that is a concentric contraction. Okay, your muscle is lifting beyond the force. Okay, and then when you're that lowering phase going down, that is an eccentric muscle contraction. Okay, which the resistance generated is greater than the force that you're exerting. Okay, you actually utilize more muscle during eccentric motions because it is a controlled failure. Okay, so if you just did eccentric contractions, okay, you actually get a really kind of crazy muscle burn and soreness from that. Really important that you have that kind of controlled eccentric contraction to prevent injuries. It is really popular for tendon development. Trying to think everything else that goes along with that. But the eccentric component is super, super important. And you guys see people working out at the gym, and if you do go to the gym or not, okay, or if you went to the gym and no one was going to the gym, okay, people like slam weight down or drop it, okay, you would actually work out their muscles more if they kind of lowered it with control, that eccentric motion, okay. Really, really important. And often overlooked. Again, if you're holding your arm just out or there's no motion occurs, that is some kind of isometric contraction, okay? And if that muscle is shortening, okay, that it's concentrically contracting, or if it is lengthening, that is eccentrically contracting. All right, central nervous system, okay? It makes up your brain and spinal column, okay? That is it. Okay. Your peripheral nervous system, okay, makes up your 12 cranial nerves and 31 spinal nerves. So your cranial nerves, okay, are all up in your head. Okay, you get 12 of them. Okay. We covered this recently. A lot of you guys actually did really well on this, surprisingly. Better than I thought you would. And that extra credit. Okay. And your 31 spinal nerves are the nerves that come off your spinal column in here. And they innervate all different parts of your body. And now I'm stuck. Okay. Your peripheral nervous system can be broken down in your somatic nervous system and your autonomic nervous system. Okay. Okay, so your somatic, okay, that controls all your muscles and that's all your voluntary control. Okay. You have a lot of your sensory, okay, your afferent and efferent nerves, okay. So like your efferent, okay, that's how you control all your muscles. And your afferent, your sensory, that's all your senses that you get in. Smell, touch, vision, movement. Movement, like knowing like where your body is in like space. Okay. And your autonomic, okay, that's your involuntary system. The stuff you can't really control. Heart rate, breathing, digestion, blood flow, stuff like that. All that's just automatic processes that happen. Okay. There's three primary functions of your nervous system. Okay. Sensory, some kind of integrative aspect, and then your motor. Okay, on how it communicates. Your sensory is the ability of the nervous system to sense changes in the environment. Okay, this is your afferent. Okay, vision, hearing, touch, taste, smell, balance, proprioception. A lot of this is going to be your cranial nerves. Okay, motor. Okay, this is your efferent. Okay, and this is how you move different muscles, joints, stuff like that. When you walk, throw a ball, etc. And then your integrative is the ability of your nervous system to analyze and interpret whatever sensory information and make the appropriate response. Like if you are accidentally place your hand against a hot surface, like the hood of your car during summer, or on a hot pan, okay, that is your sensory is going to tell your central nervous system that, oh, that is really hot, let me take my hand off of that. Okay, so take that information that, oh, I have hot heat coming from my hand. Your body is going to interpret that and it's going to send it out efferent to your motor system, okay, to take your hand off of that. Okay. Sensory receptors, okay, you have a lot all throughout your body, okay. You have your mechanoreceptors, which is some kind of response to like touch, pressure, and proprioception, which I think we'll go into here in a minute. You have your nociceptors, which is your pain receptors, your chemical receptors, which detect like smell and taste and stuff like that, and then your photoreceptors, which is like vision, light, and that different stuff. Proprioception is your body's ability to know where your joint is kind of in like space. And that is your muscle spinal fibers and your Golgi tendon organs. Okay, and these are different aspects that's encased within your muscle and tendons to kind of tell you where your posture is. Okay, this can help you improve your balance, coordination, posture when you're usually during some kind of like activity. Okay. Proprioception is also knowing where you are compared to other things. Like if you jump in your air, take a header, proprioception, if you're trained well, you're going to know where your opponent is, where your teammates are, in like close proximity. You're going to know where the ground is. Okay. If you're doing a flip, okay, you're going to know where you are in the middle of that flip, like when you want to extend your legs, when you want to bring your knees up, and so forth. Okay, so you can train your proprioception. Okay, the neuron, okay, the three different parts of the neuron, okay, you have your cell body, okay, there's your nucleus, mitochondria, lysosomes, Golgi complex, your axon, okay, which provides a lot of communication from either the brain, spinal cord, or other parts of the body. That's your larger kind of aspect of that. And your dendrites, okay, are those like finger-like projectiles that come off the neuron that gets information from other cells or other structures. Now, the neuron can have different classifications, whether it is a sensory neuron, a motor neuron, or some kind of interneuron, okay, which is usually found just in the central nervous system, okay, like brain and spinal column, okay, which only takes transmissions from other interneurons. Okay, so all these kind of play a factor on how your body kind of interprets information in response. Okay. In other classes we'll go definitely in more detail than I did. And this is just kind of generic stuff. And with that, I think we'll finish this section. Now, how do I stop this is the next question.